Welcome to the Deep Dive. We are your guides navigating complex source material, distilling stacks of research down into the essential knowledge you really need. Today, we're taking a comprehensive look, sort of a shortcut through the whole process of maternal health, from those first acronyms at conception all the way through to newborn recovery. Our mission here is pretty simple. Give you a clear, engaging path through the complex terms and, maybe most importantly, the critical safety checkpoints in obstetric care. Think of it like getting an insider's view on a really structured clinical workflow. Okay, let's start the deep dive.
Yeah, and what's fascinating is that every single term we'll talk about, it exists for one reason,
Right.
immediate risk assessment. We're going to cover that foundational language, the what and the why behind managing, a routine pregnancy, but also those high-stakes challenges during labor and delivery that need precise action. Got a lot of safety nuggets for you.
Okay, so when you first look at these clinical sources, they hit you right away with this language barrier, these letters G and P. Why is starting with Gravida and Para so fundamental? What does hearing G3P2 instantly tell a clinician? Like, why is that better than a long verbal history?
Well, Gravida and Para-GNP, they're shorthand for really critical history review. Gravida, the G, that's the total number of pregnancies, including the current one, and Para-P is the number of pregnancies that actually reached viability, which we define as past 20-week gestation.
Mm-hmm.
So G3P2 tells you immediately she's on her third pregnancy right now, and she's had 2 previous viable deliveries.
Okay. It's really clear how much info is packed in there because that GP immediately frames any other history, right? Like past medical or surgical history.
Precisely, yeah. If that P2 includes, say, a prior C-section or maybe a myomectomy for fibroids, the fact that there's uterine scarring,
Mm-hmm.
that instantly changes the monitoring strategy. It likely means more specialized care, maybe even planning for a repeat C-section, or if there's a history of gestational diabetes in a prior pregnancy, we're not waiting until the 3rd trimester this time.
Yeah.
We start checking glucose levels much sooner.
Okay, that makes sense. And that transition from just suspecting pregnancy to knowing for sure that aha moment, the sources categorize that really clearly too. It's almost like 3 levels of proof. Can you walk us through those sign categories? Presumptive, probable, positive.
Yeah, it's a good way to think about it. First up are the presumptive signs. These are subjective things in reports like nausea, feeling tired, maybe missing a period, amenorrhea.
Yeah.
They strongly suggest pregnancy, but lots of things could cause those.
Okay, suggestive but not proof. Then probable signs.
Probable signs are things a clinician can objectively find, like a positive urine pregnancy test or specific changes in the cervix and uterus during an exam. Much more likely, but still not 100% definitive.
Got it. So the only real confirmation is...
The positive signs.
Yeah.
This is the undeniable proof. Hearing the fetal heartbeat with a Doppler, actually seeing the embryo on an ultrasound, or a clinician feeling distinct fetal movements. That's it. Game over. Confirmed.
Right. Once it's confirmed, prenatal care follows this really strict but logical timeline. What's the main focus during that middle stretch, the 2nd trimester?
The 2nd trimester, so roughly weeks 13 to 27, that's largely defined by the big anatomy scan.
Yeah.
Usually happens between 18 and 22 weeks. It's a really detailed ultrasound, looking at all the fetal structures, making sure organs are developing okay. We also start tracking fundal height, measuring the uterus size. The centimeters should kind of match the weeks of gestation. It's a growth check.
And then moving into the 3rd trimester, the safety screenings get very specific.
Absolutely. 3rd trimester, weeks 28 to 40, brings 2 major safety checks. Around 24 to 28 weeks, we do the glucose tolerance test, the GTT, screening for gestational diabetes. If that's positive, it needs careful management. Then later, around 35 to 36 weeks, we screen for Group B strep, GBS. If a mom is positive for GBS, she needs antibiotics during labor. It's crucial to prevent a potentially life-threatening infection in the newborn.
Wow, yeah. Speaking of critical prevention, we absolutely have to talk about ROGAM. This sounds like a true marvel of preventative medicine.
It really is. ROGAM, or Rh immune globulin, it's essential for mothers who are Rh negative. See, if she carries an Rh positive baby, her immune system might see the baby's blood cells as foreign and start making antibodies to attack them. Not good.
So ROGAM stops that.
Exactly. It's typically given around 28 weeks, and then again after delivery if the baby is confirmed Rh positive. ROGAM basically acts like a temporary shield. It stops the mother's immune system from ever forming those dangerous antibodies that could harm this baby or future Rh positive babies. It's a prime example of proactive clinical safety.
Amazing. And just to wrap up this prenatal part, the sources give some pretty clear lifestyle advice too, right? Avoid certain vaccines, meds.
Yeah, standard stuff, but important. Avoid live vaccines like MMR during pregnancy. Choose acetaminophen, like Tylenol, for pain instead of NSAIDs like ibuprofen. Modify exercise, especially avoiding lying flat on your back after 20 weeks, because it can compress blood vessels. And that classic advice, avoid raw meats and cat litter to prevent toxoplasmosis, all standard safety guardrails.
So those lifestyle and monitoring guardrails really define the waiting period. But once those months pass, the whole focus shifts instantly to the 4 stages of labor. How did the sources break down that action sequence?
Yeah, the shift is dramatic. From monitoring to active management. Stage 1 is dilation, the cervix opening up. Stage 2 is expulsion, the actual delivery of the baby. Stage 3 is delivering the placenta. And Stage 4 is the immediate postpartum recovery period. With Stage 1 is the longest one, and it's even subdivided into 3 phases: latent, active, and then that really intense transition phase. Take you from about 8 centimeters to fully dilated at 10.
Okay, and tracking progress through those stages relies on, like, a trio of key measurements, right? What are those 3 numbers clinicians keep checking?
Right, you need 3 key pieces of data. First is dilation, how open the cervix is, measured 0 to 10 centimeters. Second is effacement, how thin the cervix is getting, measured as a percentage from 0% to 100% thin. And third, this one can be a bit confusing, is station. That measures how far down the baby's head has descended into the pelvis, relative to the mother's ischial spine's bony landmarks. Negative numbers mean the baby is still high up. 0 station means the head is engaged right at the level of the spines. Positive numbers mean the baby is moving down and out. You need all 3, dilation, effacement, station, to really know what's happening.
And progress is generally smoother if the baby's in the best position. We hear terms like cephalic and occiput anterior, or OA. What makes that OA position the easiest route?
Okay, so cephalic just means head first, which is ideal. Occiput anterior, or OA, means the back of the baby's head is facing the front of the mother's pelvis. This allows the smallest diameter of the baby's head to navigate the curve of the pelvis. It's the optimal fit. Now, if the baby is occiput posterior, OP, meaning the baby's spine is against the mother's spine, well, that often leads to what people call back labor. It's usually much longer, significantly more painful.
Oof, yeah. Now, the sources are also really clear about some critical complications that need immediate action. We mentioned infection risk with prolonged rupture of membranes, water broken over 24 hours.
That's definitely a concern, yes. But probably the most emergent high-stakes event described is a cord prolapse. This is where the umbilical cord slips down ahead of the baby. Then, when a contraction hits, the cord can get compressed between the baby and the pelvis, cutting off the baby's oxygen supply. It's a true emergency.
Wow, what's the response?
It's immediate and dramatic. The nurse or doctor has to physically push the presenting part, usually the baby's head, up and off the cord to relieve pressure. Often, the mother is put into a knee-chest position to use gravity to help shift the baby back, and everyone starts prepping for an immediate emergency C-section. No time to waste.
That really underscores how quickly things can change. Now, for managing the pain through all this intensity, what are the main medical options the sources talk about?
The 2 big ones are the epidural and spinal anesthesia. An epidural gives continuous pain relief through a small catheter in the back. Big risk is potential hypotension, low blood pressure, and it limits mobility. Spinal anesthesia is usually a single, stronger dose injected directly into the spinal fluid. It works faster, often used for planned C-sections. Both work well, but they have different applications and side effect profiles.
Okay. And before we get to recovery, let's quickly touch on stage 3, delivering the placenta.
Right, the 3rd stage. This should ideally happen within about 5 to 30 minutes after the baby is born. If it takes longer, that's a retained placenta. And the big risk there is postpartum hemorrhage, serious bleeding. This stage is also when delayed cord clamping might happen, letting the baby get a bit more blood from the placenta before clamping.
Okay, so the baby arrives, and immediately the clock starts for the APGAR score, 1 minute and 5 minutes. What 5 things are being scored, and why are those first few minutes so predictive?
The APGAR is a super quick assessment of how well the newborn is adapting to life outside the womb. We score 5 things using the acronym APGAR: appearance, skin color, pulse, heart rate, grimace, reflex response, activity, muscle tone, and respirations, breathing effort. Each gets 0, 1, or 2 points, total score out of 10. A score below 7 at the 5-minute mark usually means the baby needs some help, maybe ongoing resuscitation or closer monitoring. So yeah, it's a really good, fast snapshot of the baby's overall condition right at birth.
This brings us to something I find absolutely fascinating, that newborn transition. The whole fetal circulatory system, which relied on the placenta, has to basically rewire itself in minutes, even seconds. What are those three fetal shunts, and how do they just
It
close?
is truly a biological marvel. In the womb, the baby's lungs aren't used for breathing.
Right.
So the circulatory system has these three clever shortcuts or shunts to bypass organs that aren't fully needed yet.
Hmm.
First, there's the foramen ovale. It's a little flap or hole between the heart's upper chambers, the atria, that's blood bypass the lungs. Second, the ductus arteriosus. This is a blood vessel connecting the pulmonary artery directly to the aorta, again bypassing the lungs.
Okay, so two lung bypasses. How do they close?
That first big breath the baby takes floods the lungs with oxygen. This dramatically changes pressures inside the heart. Pressure on the left side goes way up, and that slams the foramen ovale shut. The increased oxygen also signals the ductus arteriosus to constrict and close, usually within hours or days.
And the third one?
The third is the ductus venosus. This one bypassed the liver, shunting blood from the umbilical vein directly to the major vein returning to the heart. When the umbilical cord is clamped and cut, blood flow stops, and this shunt closes off too. The whole system basically reroutes its plumbing on the fly. It's incredible.
That level of immediate change is just staggering. Okay, beyond that amazing physiology, what are the standard immediate things done for the newborn, according to the sources?
Three key things are pretty standard right after birth. First, a vitamin K injection. Newborns don't have enough gut bacteria yet to make their own vitamin K, which is essential for blood clotting. This prevents bleeding issues. Second, erythromycin eye ointment. This prevents a serious eye infection called ophthalmia neonatorum, which can be caused by exposure to bacteria like chlamydia or gonorrhea during vaginal delivery. And third, usually the first dose of the hepatitis B vaccine is given right there in the hospital.
Okay, crucial protections. Now let's shift back to the mother for stage 4, that immediate postpartum recovery phase. What's the absolute top priority then?
Without a doubt. Preventing hemorrhage. Bleeding is the biggest immediate risk after delivery, so the focus is heavily on the fundal assessment. Clinicians regularly check the uterus, the fundus, by feeling it through the abdomen. It needs to feel firm and be midline. If it feels soft or boggy, that means the uterine muscle isn't contracting properly, called uterine atony. That requires immediate, vigorous fundal massage to stimulate contraction and stop excessive bleeding. It's critical.
And we also monitor lochia, right? The vaginal discharge that changes over time.
Yes, exactly. Lochia follows a predictable pattern. It starts as lochia rubra, bright red blood like a heavy period for the first few days. Then it transitions to lochia serosa, more pinkish or brownish and watery. And finally, lochia alba, yellowish or whitish discharge. Any regression, like going back to the bright red after it was pink, or a sudden gush of blood, is a warning sign that needs checking. The whole postpartum assessment is often remembered with the B/BA mnemonic: breasts, uterus, bladder, bowels, lochia, and episiotomy perineum. It's a quick way to cover all the key recovery checks.
Got it. And just to close the loop on recovery hormones, we mentioned prolactin and oxytocin.
Right, prolactin is the main hormone driving milk production, but oxytocin, often called the love hormone or bonding hormone, does double duty here. It triggers the milk let-down reflex, allowing the baby to feed. And crucially, oxytocin also causes those strong uterine contractions after birth, helping the uterus clamp down, shrink back to size involution, and prevent bleeding. It's vital for recovery. So maybe to kind of synthesize the clinical management aspect, let's touch on three key high-alert medications that really highlight how specialized OB care is. First, oxytocin, often given as Pitocin. We use it to induce labor or make contractions stronger if labor stalls. But, and this is crucial, its use requires constant monitoring of the baby's heart rate and the contraction pattern. We have to watch out for tachysystole, too many contractions too close together, which can stress the baby by reducing oxygen flow.
Right, careful balance needed there. And the second big one is for a specific high-risk condition, preeclampsia.
That's magnesium sulfate. Now, importantly, it's not primarily used to lower blood pressure in preeclampsia, though it might have some effect. Its main job is to prevent seizures, or eclampsia, which is a life-threatening complication. But magnesium sulfate is a potent central nervous system depressant. So nurses have to monitor the patient extremely closely, checking deep tendon reflexes, respiratory rate, urine output. Overdoses can cause respiratory arrest. We always keep the antidote, calcium gluconate, right at the bedside, just in case.
Wow, high stakes indeed. And finally, the sources mention heparin as the anticoagulant of choice. Why specifically heparin in pregnancy?
Good question. Pregnancy itself makes women more prone to blood clots. It's a hypercoagulable state, so sometimes anticoagulation is needed. The problem is many anticoagulants, like warfarin, can cross the placenta and harm the baby. Heparin is preferred because it's a larger molecule, and critically, it does not cross the placenta, so it treats the mother's clot risk safely without affecting the fetus.
That makes perfect sense. Okay, finally, just to touch on the full scope of safety, this includes screening for STIs, right? Sexually transmitted infections.
Absolutely. Comprehensive prenatal care always involves STI screening, chlamydia, gonorrhea, syphilis, HIV, because some of these infections can have devastating consequences for the newborn if not detected and treated. The sources specifically highlight the danger of active herpes, simplex virus, HSV, lesions during labor. If a mother has an active genital herpes outbreak when delivery is imminent, a C-section is generally mandatory to prevent the baby from contracting neonatal herpes during vaginal birth, which can be incredibly severe, even fatal. It just shows how everything connects the patient's entire health history impacts those critical decisions right up to the moment of delivery. Hashtag outro. So ultimately, what the sources really show us is how all these different pieces, the acronyms like GP, the timings of screenings like the GTT, the stages of labor, knowing if the baby is OA or OP, they aren't random. They all fit together into this incredibly complex but highly integrated system focused entirely on risk management. It's a clinical workflow really engineered to anticipate problems and ensure the safest possible outcome for both mom and baby.
Yeah, and knowing this framework, understanding the why behind these steps, really empowers you, the listener, the learner. It lets you have more meaningful conversations with healthcare providers. You move from just accepting care to being part of informed, shared decision making. Okay, and we'll leave you with this final thought to chew on, building on that amazing newborn transition we talked about. Given that a baby's entire survival outside the womb depends on the rapid, perfect, functional closure of those three critical fetal shunts, the foramen ovale, the ductus arteriosus, the ductus venosus, what does that immediate, no room for error complexity tell us about the sheer, almost unbelievable resiliency built into the human body? That capacity to instantly shift from totally dependent uterine life to fully independent existence is just a moment of profound, powerful biological change. Really makes you think.